And this will make an important part in making a delivery decision of more than 32 weeks. Less than 32 weeks in India, whether we're going to deliver 28, we'll just come to that question. And later on, if it is after that, it should be delivered immediately. After these three arteries and of course the fetal aorta, we come to the fetal venous Doppler, which tells us that there is a acidosis. Now fetal Doppler vein, umbilical vein, ductus venosus, inferior vena cava. Umbilical vein, you should get a clear pattern, straight. Ductus venosus, you should get an M pattern. And inferior vena cava, simple pattern. So this Dopplers in the venous system will reflect that this baby is having hypoxia, hypoxemia or acidosis. And that makes it very dangerous, because whenever the hypoxemia sets in, next will be hypoxia and next will be acidosis. So these babies will die if you're not going to take. Venous Doppler is more important when the babies are smaller, because it is telling you the cardiac function. And it is telling you that this baby is going to be. So ductus venosus is a small organ where the umbilical has entered and entering into the inferior vena. So dono taraf low flow hai, and that small organ is a high flow. So you'll see very bright high flow, and you see the M pattern with the diastole, and you see the M pattern reduced and reversed. So if reversed is occurring, then this baby is dying. So first trimester, there will of course, like all, will be less diastole. Then the diastole will be very high in the third trimester. If the diastole is reversed or zero, then the ductus venosus pattern is abnormal. And that means there is hypoxia, acidosis. So ductus venosus normal, ductus venosus reversed or acidosis. Okay, very clear, simple. Very easy to make. It is a decision-making vessel for immediate delivery in the late second or the third trimester. In the first trimester, it tells you about chromosomal anomalies, cardiac defects. So that is, and after, if it is reversed, pre-terminal fetal acidosis. That means this baby is dying. Umbilical vein should be straight. If you see pulsatile like this, a bad sign. Again, acidosis has occurred, fetal cardiac function is compromised, and this baby is dying. So inferior vena cava, you start seeing you see two normal with diastole. If you see reversed, this is normal ductus venosus, this is normal inferior vena cava, and if it is abnormal, more reversed in the inferior vena cava and abnormal in the ductus venosus, the baby is absolutely terminal and immediate delivery is required. So now the timeline. First will happen abnormal fetal growth, because aorta is not supplying blood. Second will happen umbilical artery and middle cerebral in 2 weeks. Then abnormal venous Doppler. Then abnormal NST. So abnormal NST occurs almost 3 weeks later than the color Doppler would have picked up that there is this baby in problem. So don't depend on NSTs. So growth lag, cerebral blood, umbilical blood, redistribution, more fetal weight loss, then end diastolic absent, reversed, then biophysical profile, then fetal death. And amniotic fluid will start decreasing from here. So amniotic fluid is also a very, very important indicator of marking. Action point is, at 33 weeks, if you see this, you need to deliver. At less than 32 weeks, if you see reversed, you need to deliver. Then these babies are not going to live inside. So these are your action points. And before that, if you see these here, then your treatment, whatever you want to give, which very less treatment work here. Now intervene in time. So monitor growth by biometry, measuring BPD and all, monitor hypoxia by Doppler, prevent acidemia by biophysical profile CTG, and a daily fetal movement count. This is what the patient monitoring has to be done. How often? If it is early, then you can do 2 weekly. If it is early mild, again 2 weekly Doppler. If it is severe, then you need to admit, and even every alternate day Doppler till you decide. How do you look for what? Fetal anatomy, differential diagnosis, fetal growth, placental performance, amniotic fluid index, placental performance, uterine artery Doppler, mother side, umbilical Doppler, fetal side of placenta, middle cerebral Doppler, cerebral vasodilatation adaptation, venous acidosis, dynamic variable, that means biophysical profile, the behavior state of CNS, and all the others. So these are the tests, and that is what it tells. What about anemia? Whenever there is anemia, the heart is going to beat faster because you need more blood. So increase cardiac output, blood viscosity, so increase blood velocity, so PI will increase, and in the brain especially, in the middle cerebral, the wave area in between the systole will all appear as black. Here it is appearing normal, so it will be appearing black in the center there are less RBCs. So the area shading inside the wave would be dark and not white. That is how we try to, and of course pulsatility will be very high. Whether notching is important or not, if notching disappears, very important, it tells you normal. If with increased diastole there is still notching, it's not here, but if still notch is there, this diastolic notch persists, then mild PIH can occur. So that is the latest. 3D color Doppler can be used. This is placental 3D color Doppler. Not much of clinical value right now, but maybe values will come. 3D tells you vascularization index, 3D tells you flow index in that organ, or FI and VFI, and 3D will calculate how much blood is going into each cotyledon and all that. And there is enough data now that 3D is not required, and the color Doppler. Now lastly we come to the staging part. So itne sare ke baad, do we have a clinical staging? Yes, we have a clinical staging, and this staging will be stage 1 when your umbilical has become like cerebral and your cerebral has become like, so there is altered cerebral placental tissue. Stage 1 growth retardation, and this is where your treatment starts happening or your vigilance starts happening. Stage 2, the cerebral is increased to 50, the umbilical has become 0 or reversed, and the ductus venosus is also affected now. Stage 2 I use here. So this needs admission, this needs steroids and Magsulf to the patient, this needs delivery within 72 hours. Stage 3, when everything is reversed. So everything is reversed, this baby needs to come out within 24 hours. Very, very simple. Then they are divided into A and B also. So if amniotic fluid index is less than 5, it is A. So any stage 1A, B, 2A is dangerous, because amniotic fluid index less than 5 can kill the baby anytime. Baby, like we need air, baby needs water. If amniotic fluid is more, stage 2B can also be prolonged for a few days by conservative treatment if you want to buy some time. That is how we classify these. So the purpose of this is that clinically we can assess that how much time we can give. Stage 1 mild growth retardation, we can treat these patients OPD. Stage 2 and 3 need to be admitted. Stage 2 patients are admitted for observation if the amniotic fluid is normal, can prolong. If stage 3 patients are high risk of fetal death, have to be delivered. So very simply we can put the staging and put the delivery. The advantages are the parameters are simple and parameters are easy. Only thing you have to remember, you have to study all the 4 vessels. And you cannot make this thing, and the staging can be applied very simply on all the patients, and that is what this study of the data. How do you do the delivery? You have to determine whether it's very premature, whether your facility has an ICU or not, whether there is a acidemia or not. If all this is happening, deliver the baby in a tertiary care center which has good NICU. So objective is because we want to give a live baby to a live, and this was the truffle study which compared Doppler and CTG for delivering, and they said that if you have end diastolic flow before 32 weeks, you need to deliver. End diastolic flow at 32 weeks, increase PI at 36 weeks. Even end diastolic flow is not reversed, you still need to deliver. So that's what this study says. So less than 20 weeks in India, controversial, social decision, not scientific. In USA they'll deliver even 500 grams, even if the baby turns out to be blind at 20 weeks because of lens not formed. In India it is a big challenge. We can, rather than giving a cesarean scar, we can sacrifice this baby and plan for the next baby. That is my personal opinion. That is not a scientific opinion. Because that's absolutely not, and that is only for India, Pakistan, Bangladesh, Nepal areas, not for US countries. They do not believe in this. 28 weeks, parents have to be counseled, and the challenge is there. And we saw in the headlines in Apollo, one baby delivered and parents did not give DNR consent and all. 28 to 32, abnormal biophysical profile, admit, treat conservatively, give Magsulf for fetal cerebral maturation so that the cerebral palsy does not happen, and give steroid cover, Decadron, not betamethasone now. It is now, because betamethasone, the solvent is different and that does not work. We were taught as betamethasone, but now it's changed to Decadron. 12 milligram BD for 2 days or 3 days and then deliver. And went to the 32, 34, give steroid Magsulf, deliver. More than 34, abnormal Doppler, you can deliver without steroid therapy. More 34 to 37, deliver anywhere you are. So these babies will require the minimum NICU care, and if basic NICU care is there, you can deliver them baby. How do we manage expectantly? Expectant management is steroids, fluids, modified bed rest, lifestyle management, maybe arginine, things like that, but none of them work. So the delivery is decreased diastolic, absent diastolic, reverse diastolic after 34 weeks. 24 to 31, discuss with family. 28 to 32, steroids and deliver. After that, you can deliver easily, even if steroids you don't have a chance first. This was a consensus which was formed in Berlin. I was a part of it. The three of us formed a consensus on early pregnancy rate, and this was known as the Berlin Consensus and we made this on what we called as the gestation-related optimal growth, or the grow thing. And we made this chart that at 24, let that baby go. At 26, extensive monitoring. At 30, at 34, steroids. And we made this chart and put forward as the Berlin Consensus. And we also said that if you don't do, this is the road to death. So if you don't do something here, then the baby will die finally with an abnormal NICU. And that is what the sequence will happen. So this is our original work, my original work, with two of these, French and the German fellow. So to conclude, every detail of the history of the patient, antenatal growth, Dopplers, umbilical vessels, all has to be done. All 4 vessels have to be done. Venous Doppler will help in acidosis. Aortic ischemic Doppler is very important, where we don't have this facilities to do that, only a very expertise, but that can pick up. The take-home message is small for gestation age babies. Babies may be small, and they may be constitutionally small, and they may be growth retarded small. So you have to distinguish between a growth retarded baby, which is going to be problematic, and a small constitutional baby will have no problems. You can deliver 2 kg baby normally at full term without any problem. So, and the majority of these, you cannot say that all high-risk mothers only will have, they also occur in low-risk pregnancies. So each pregnancy is a high-risk pregnancy, and each pregnancy need to be screened well. And commonly all these growth retarded are because of placental problems. So abnormal placentation, and that has to be picked up early at 3 months so that aspirin can be started and delivery. So dating of pregnancy is very, very important. You have to go by the first ultrasound date and not by later dating. And deliver at 34 if there is deterioration. Uterine artery Doppler used for screening, umbilical used for diagnosis, middle cerebellar used for brain sparing, and ductus venosus used for delivering the babies. If the diagnosis of IUGR, if the Doppler is normal, IUGR diagnosis, or F.G.R. we should say now, is doubtful. Okay, it may be just a constitutionally small baby, and small fetuses with normal Dopplers are left alone to go to term and deliver normally. If Doppler is available and you have to do only one, do it 28 weeks. Otherwise, 3 Doppler examinations at 12, 20, and 28 to 40 are required.